Hello, and welcome to the Duke Cardiology Conference. I'm Sunil Rao, Associate Professor of Medicine at Duke University Medical Center. Today's program, we will recap the results of the exciting ACC 2011 and I2 Summit conferences that were recently held in New Orleans, Louisiana. And my distinguished guests today are Ken Mahaffey and John Alexander, both co-directors of the cardiovascular group here at the DCRI. Thanks for joining me.
Thanks for having us.
Great to be here.
So, another exciting conference at ACC, the second big sort of American conference, lots of late-breaking clinical trials. What I thought we'd do today is sort of review some of the results of some of those trials very briefly, talk really more about what the impact they're going to have on overall practice, then maybe talk a little bit about where we think clinical trials are headed, given the fact that we've had the presentation of some of these mega trials at the ESC 2010, AHA 2010, now ACC 2011. And I think what our audience will notice is that some of these trials have come up with some mixed results a little bit, and we need to sort of think about where to go. And then maybe spend the last half really just talking about where we're headed with conferences in general. I mean, with the explosion of technology now, we notice the fellows are much more savvy with technology than probably we ever were, and how they're getting their clinical information from these conferences. So in terms of major trials, there were two sort of big valvular heart disease trials that we should touch on. The first, of course, that has gotten everybody excited is transcatheter aortic valve implantation. We heard about the one cohort from TAVI from the Partners trial at AHA. They presented the more recent data from the other sort of surgery head-to-head comparison. Ken, I'm going to start off with you. Sort of what's the big take-home message from TAVI in general? Maybe not just as it relates to Partners, but where the overall field is headed.
Well, I think the overall field's heading in a good direction for our patients because it's going to provide a really viable strategy that doesn't require surgical intervention and the risk that surgery carries up front when patients go to the operating room. It's a risk we don't want them to have, but they do, going under anesthesia and having open procedures performed. So I'm very excited about the field.
I think one of the most exciting things about these percutaneous valves is the collaboration they're building between surgeons and cardiologists. I mean, really having to work together in new ways that they haven't before, and since the early days of percutaneous intervention, really. And I think there's a lot more we'll see going forward with new ways to manage patients with these percutaneous valves.
Yeah, AHA, I think that was sort of, or TCT rather, was a very exciting time when we started talking about TAVI for patients who are not surgical candidates. Right. And that seems relatively straightforward. Now we're starting to talk about that versus surgery. Right. So John, I mean, where are we going with this? I mean, we see in Europe, for example, this tremendous diffusion of this technology. I mean, 15,000 patients in a registry getting TAVI, some of which probably are lower risk than we would have expected. Yeah. What are the dangers here?
Well, I think the first thing you said is one of the important caveats here: patients who are not candidates for cardiac surgery. And so I think there's already judgments in that. And certainly at big academic centers, we have different thresholds for who we're willing to put through that risk and have that conversation, importantly, have that conversation with patients. As I agree with you, I think as this less invasive technology gets out there, gets more hype about it, we do run the risk of it being used in populations it hasn't been as extensively studied in. And we certainly don't know any long-term outcome data with TAVI yet, which I think is going to take time, obviously, to come up with.
And Sunil, I think two other key pieces of information that came out at the ACC meetings were one was the Echocardiographic Substudy that Pam Douglas presented, where it showed that over 12 months of follow-up there in the cohort B, the non-operable cohort, that there was maintenance of the aortic valve area. So there was no diminution of the aortic flow, which is very important, I think. Obviously, I think it's even more important to follow those patients longer to see what happens after 2 years or 3 years. But it was surprising that we didn't see any LV mass regression, which some people thought would happen if you improved left ventricular outflow. And then the second thing was the cost effectiveness analyses. Yeah. You've done a number of those analyses yourself in the past, and this showed that for the cost effectiveness of the procedure, it's in the ballpark of what we typically anticipate, about $50,000 per year of life gained. Yeah. So very encouraging.
Yeah, and I think the two dimensions that are somewhat worrisome to me, and we've seen this before in almost every kind of technology, is this sort of risk treatment paradox. Are we going to end up, if we project 5, 10, 7 years down the road when this technology is available, that all of a sudden we're actually using it in the lower risk population because the outcomes are going to be really good versus the higher risk population? Right. And then the other issue is, how does the evidence keep up with the technology?
Right.
My guess is that by the time we're talking next year, there may be new iterations of this device.
Right.
So, I mean, how do we prevent that? Or should we have centers of excellence? Should we have training programs that are specific to this kind of thing? What do you think?
I mean, I think the changing technology is a problem we face, really. I mean, specifically in the device world. It's a bigger problem in the device world because of the need for long-term follow-up and the ability to make minor changes to these devices, minor improvements, we think, to these devices going forward. I don't see a solution to that. I mean, I think we're going to continue to make minor changes to these valves, and particularly as we get into lower risk patients who are going to have longer lifespans, you know, the question is, so where's the 10, 20-year follow-up data on these percutaneous valves?
Yeah, I mean, I agree with what John said. I'd also add that I do think that there has to be some centers of excellence that are created, both centers of excellence for clinical care, centers of excellence for training, how to do these procedures. So we're all on the steep part of the learning curve as quickly as possible for those people who do these procedures. And then finally, I think there has to be a commitment in the research community and the regulatory community that we're tracking what kind of patients these devices are being put in registries or other systematic centralized data sets, so that we can monitor the use over time, the application of the device and the procedure to certain patient populations over time, and learn from the experience as we go. And then, of course, for us, it drives fascinating scientific queries from large data sets like that can only help us all.
I mean, this is really a great place for post-market registries. I mean, it's a relatively niche, identifiable procedure device. You know, it'd be really nice to get some global registries going to really learn from this.
Who should do this? I mean, is this a professional society thing? Is it? I mean, should industry? I mean, if you're making the device, are you obligated to provide a training program? Should it be a collaboration? Who's going to take on the charge of doing the education, the registry, the?
Great question. Great question.
I have my opinions. I want to hear what you think.
Well, how about I'll ask you first?
Okay.
Obviously, I think it needs to be a collaborative effort. And that's the only way that things like this are ever successful. Because if you don't get people engaged, enthused, motivated not only initially but over time, then it doesn't work. I think what you're alluding to, though, is two things. One is, who's going to mandate it? And then number two, who's going to pay for it? And I think those are the tougher questions. But I think if we can all agree that it should be done and in a collaborative approach and who the stakeholders are, then we can have the tougher discussions. What do you think?
No, I absolutely agree. In fact, I think that it's really, the onus is actually, in my opinion, on our profession. I mean, this is a technology that we're going to be using. And if we don't prove to the public that we're doing it the right way, someone's going to do it for us. And that's going to be a problem.
Yeah, I mean, the mandate piece, though, has to be driven by somebody who's organized and centralized enough. And our profession, I would say, maybe absent our big professional societies like the ACC and AHA, isn't really organized. But those professional societies could really play that kind of a leadership role. And then obviously government payers could play that kind of a leadership role.
Yeah, I totally agree. So let's move on now to a similar type of patient population, sick patients with heart failure, Stitch.
Yeah.
Big DCRI, NHLBI effort, tremendous amount of work on the part of the investigators and the steering committee. John, summarize for us just sort of a little bit about what Stitch was about.
So Stitch was, as you said, an NHLBI-sponsored mega trial, both in terms of its size, I mean, with several thousand patients, but also in its scope. I mean, this is, I think they started planning Stitch 7-8 years ago. It enrolled a very high-risk patient population with coronary disease and reduced LV function and heart failure, and really addressed a fundamental question: should they get surgical revascularization or not? That was the key question in Stitch. There was also a second question about LV remodeling. And so, they went for the definitive outcome of all-cause mortality and had very complete follow-up. And at the end of the day, they presented the results at the AHA and at the ACC, and there was a modest improvement, I would say, in 5-year mortality with surgical revascularization. I think, as we've seen in many of these surgical trials, it starts off with an increased risk in the surgical group. So it's always a complicated trade-off question with patients. I think what Stitch really provides us is a lot better data to have the same conversations we've been having for years with patients.
Ken, you take care of these patients in the Duke CCU, and one of the things that we always talk about is viability.
Right.
You know, this is the one thing that we always want to see in these patients who have reduced LV function. How much myocardium are we going to save? There was some very interesting viability data that came out of the ACC. Tell us what that showed.
Yeah, so Sunil, I think it showed two things. Excuse me. First of all, it showed that patients who had viability did better long-term than those patients who didn't. So it confirmed prior data and knowledge. But the second thing, and what really surprised many of us, was that there was no difference in outcome between the two strategies if you had viability or not. And so this whole theory of you've got functional myocardium that doesn't have enough blood flow, and you fix the blood flow problem, you should get better LV function, and you should do better long term. And that just was not the case. Now, we had lots of discussion, as you know, at the Duke Cardiology Grand Rounds on Monday night about this very thing. And you know, I think the first thing that's going to make me think about is, do I need to order all these viability studies? Now, the two questions that people have raised since the meetings is, one, was viability assessed in the right way with the right modality? And I think it was a very vigorous assessment of viability. But the other thing that people have wondered is, was it viability or is it ischemia? And doing analyses based on those kind of data from the information that the investigators have from STITCH will be very, very important.
Yeah, like most NIH-funded trials, STITCH has a lot of ancillary data. Makes it more complicated, harder to run, but boy, we will get a ton of information over the upcoming years from the STITCH database.
So in your opinion, John, I mean, what is the utility of obtaining viability data? Is it simply to provide more information to the patient, to basically a risk assessment tool?
You know, I think it adds to risk assessment, as we saw from the data from STITCH. But there, you know, that's on top of dozens of other clinical variables we have. So I think what it has done in the past is made people more comfortable with accepting this upfront risk of surgery, thinking they're going to get more benefit out of it. And I think, so I see this as a negative finding from, a very important but negative finding, that viability testing doesn't add predictive value to the benefits of surgery over medical therapy in the overall population. Again, there's more exploratory analyses to do.
I'm glad you used the term negative, because we have actually seen a slew of negative trials, really, that have sort of challenged our fundamental paradigms. I mean, there was Gravitas at AHA, there's, you know, the viability aspect of STITCH at ACC. The other trial that was surprisingly negative was the RIVAL study, which is the 7,000 patient trial, patients undergoing both diagnostic angiography and or PCI, randomized to radial versus femoral, predominantly an OUS study, just because there isn't that much radial use in the US. No difference overall in terms of death, MI, stroke, or major bleeding. Were you surprised by that, Ken?
I was a little surprised by it, Sunil. You know, I'm not, and nor is John, a card-carrying member of the interventional community, so we don't do these procedures. But I was a little surprised, and particularly because, as you know from RIVAL, we also saw that there was decrease in bleeding complications and vascular access complications. And we've struggled for many years now to understand the link between ischemic complications and bleeding complications. But we know that there is a link there, they're associated somehow, and those events are also always associated with long-term risk, morbidity and mortality. So I am a little surprised that because you had essentially a cleaner procedure, that we didn't see more benefit or a better signal of benefit on the ischemic clinical outcomes side. I'd be interested to hear your thoughts on, you know, the interesting subgroups that were discussed quite at length at the late-breaking clinical session and then in subsequent venues at the ACC. This issue about operator volume and the relationship to the findings of a statistically significant interaction term, and then also in the non-STEMI population that had a significant interaction as well. That I was even more confused by that one.
Right, absolutely. Yeah, no, I'm not only a card-carrying interventional cardiologist, but I'm a card-carrying radialist, and I can tell you that the cards that we carry have very big letters on them at the reading level. But you know, we were surprised by those results. But then when you actually delve into the study, it's very interesting. I mean, it was obvious that these operators were skilled operators. the rate of major bleeding overall in the trial in both arms was 0.9%, 2/3 of which was non-access site related. So you wouldn't expect the intervention to affect that.
And that was a fascinating
That was
finding,
amazing, yeah.
because many of us have not necessarily spent a lot of time looking at the types of bleeding
Exactly, yeah.
in these interventional trials. So it was something that I think in the research community in particular,
Yeah.
we're going to have to think more about as we're designing future trials, and then in the clinical community, that we got to make sure people aren't bleeding in other places when
Absolutely.
we're giving them potent anticoagulants and antiplatelet agents.
Right. I mean,
sorry to interrupt,
no,
but
I think that's absolutely
really
right.
key.
And I think for the clinical community, it tells us that you need to have a variety of approaches. If you're a radial person, you say pharmacology doesn't matter, or vice versa, you're probably just seeing half the picture.
Right.
And you always want to be careful when you interpret positive subgroups from negative overall trials. But there are some interesting issues. I mean, the mean annual PCI volume per operator in the trial was 300 cases a year. That is a lot of cases compared with any U.S. operator. So these were expert operators. And I think also that explains this interaction between the operator and center volume and outcomes. I mean, the more you do, the better you're going to get at it. The STEMI thing, where we saw a lower mortality, that's a little bit tougher to explain. There was no difference in bleeding. There was, a significant difference in access site complications. Maybe they're worse in the STEMI population, perhaps. This confirms previous small studies that do show an association between radial approach and improved survival in the STEMI population. The caveat to that, obviously, is that unless you're an expert radial operator that works in a center that is used to doing radials, you probably shouldn't be doing primary PCI, because after all, we're all subject to the door-to-balloon time ticker now, so you've got to be a little bit careful.
Just one other, from a trial standpoint, important caveat about Rival is that there's no way to blind it.
Right.
So one has to be careful about different management strategies, different assessment of outcomes in the two arms.
Yeah, I think you're absolutely right. And it's interesting when you start thinking about doing a randomized trial of radial versus femoral. It seems easy, and then you realize, wait a minute, femoral operators can't randomize to radial. They don't know how to do it. Radial operators won't randomize to femoral because they switch to radial for a reason. So it becomes a little bit more challenging than we think.
Selected population that gets randomized, selected group of investigators.
Exactly. And I think you brought up this issue of what it means for clinical trials. As we start thinking about some of these negative studies, it's easy, I think, to get depressed. What's your perspective on negative trials, Ken?
Well, I mean, there's been lots of good discussion about this. I actually look at no trials should necessarily be called negative, because it always promotes great discussion. Hypotheses that can be generated from these large data sets. And so when we think about them as positive or negative, that's in the context of, is this drug or device been shown to be better, and did the trial reach its primary objective? So in that setting, positive and negative are fine.
But the connotation is a bad one,
But the
isn't
connotation is potentially a bad one, because then people just, if it's negative trial, they may just disregard what could be learned from that for either designing future trials, understanding how maybe it's an FDA already approved drug or device, that figuring out how it could be used in certain populations a little bit better. So always good things to learn from good big databases.
I also like to throw the result of neutral in there. Rival's really a neutral trial, not a negative trial, right?
Yeah,
So
exactly.
We have had some negative trials.
Right.
Negative is when you're hurting people, which is what we clearly don't want to be doing.
Right, exactly. Plus, I think it's important because it tells us what we probably shouldn't be doing, or probably be more selective about what we do.
Exactly.
Now, what's interesting, I want to change gears a little bit here, because we've talked sort of offline periodically about what is becoming the utility of these large conferences nowadays. This is a little bit different, where people are having incredibly busy practices. As we mentioned, the new generation of cardiologists and cardiology fellows are much more tech savvy. Tell us a little bit, both of you, about the efforts that DCRI is doing, for example, to bring technology into the world of education, and how we're dealing with dissemination of a lot of data from one meeting to the rest of the clinical community.
Well, I mean, so let me start with just, I think, what's happening in the world, and not just DCRI. I mean, the ability to get information, to get access to data, to get access to results to trials, real time, I mean, immediately, maybe sometimes minutes before they're presented, is just unbelievable now. And there's, you can do this at the ACC. If you're sitting in another lecture hall, you can watch the late-breaking trials on theheart.org or any number of other websites, and see the presentations, get the slides, see the actual presentations live. And that's sort of ubiquitously available. And it really has changed the dynamics of these meetings. I think it's changed who goes to them. I think it's changed who goes to which sessions at the meetings.
Yeah.
It changed what people are talking about. The information's out there very quickly. And then there's all this news media at the ACC and AHA all over the place that people are getting information from instead of actually physically having to go to an individual session.
Yeah.
Yeah, I agree. It's almost a media bombardment. I polled the Duke faculty the other night and asked them what was the most common source of information from the ACC meetings, and was it word of mouth, actually attending the sessions? Was it all the emails that they got automatically from the Heart.org or the ACCs or ACC or CardioSource or a number of other news agencies? Or was it proactive internet browsing? And it was amazing. None of the faculty said it was attendance was the most common.
Is that
right? Doesn't
right?
mean they weren't at the meeting.
Right.
Or they were on Bourbon Street. It's unclear where they were, but they did have plane tickets to New Orleans. But it was really, the majority was all about internet browsing and the emails and then word of mouth. So it really shows that this is how people are starting to rely on media to gain the knowledge and not feel that they need to run around the sessions. And I think it's great because you can be in touch all the time. You know, our cardiology fellows at Duke University at the DCRI developed a fellows blog that anybody can have access to. And I joked with them a little bit about it because it's a lot of great science with a little bit of what I call People Magazine.
Yeah.
What's going on?
Right.
And so they did interviews with leading cardiologists, leading investigators around the world. They had a Flickr, they had Twitter,
Wow.
and downloads during the course of the entire day, as well as access to the slides of all the presentations for the investigators that would give them to them. So a really valuable resource that links into other things that we're doing here, such as Mike Gibson and his clinical trials result with Duke TV, and a number of other websites. So I really think that we're going to continue to harness those kind of media activities to really educate the clinical community, the scientific community from these large meetings.
Bob Harrington and Rob Califf here have said that we're getting out of an era where the experts are those people who know the data, and we're getting into an era where the experts are those people who can take the data and transform it into knowledge. And I see the DCRI Fellows blog as doing that. So it's no longer a matter of being able to get the slides from the presentation. I mean, everybody can get the slides from the presentation. Now it's a matter of being able to talk to people and interpret the information and figure out what does it mean for future research, what does it mean for clinical care. And that's where I think the media is going to go in the future and really have more dialogue, more conversations with people.
And I think that the societies are going that way as well, Sunil, not just with the websites that are associated with each of the major scientific organizations. But as you know, the AHA has just announced this Emerging Sciences program that, between the meetings, lots of good science is being done and completed the 6 months between the meetings. This would provide a venue by which on the internet, through video conferencing and videotaping, they would have the presentation of late-breaking clinical trial type programs or key analyses from trials that have already been presented or published, and do it. It would just almost be like an isolated late-breaking session with a presenter, a discussant, and a panel. And hopefully have publications along with that in the major journals. So if people are interested in this, I think the societies are taking this on, and this is going to be a great opportunity to keep good science coming out year-round so that we're not just stacking it up to wait for the opportunity to present at some of the major congresses that you've already mentioned, ACC, AHA, European Society, TCT.
Right. And what's amazing about these blogs or Heart.org forum where people can post is that it really has shrunk the clinical community. I mean, when you get comments from people who are, in the trenches taking care of cardiology patients in Bulgaria and Eastern Europe and and they're facing similar issues and similar clinical questions, it's really sort of humbling when you start thinking
and I
about
think
it.
you're starting to see regulators in there. You're starting
Right,
to see
absolutely.
industry in there.
Yeah.
The academic, the clinical community. Yeah.
Now, I'm going to ask you a question that's a little bit out there, but I think it is probably where we're headed. I mean, if the clinical community has, is all sort of interacting now in an online fashion, does that change the way we think about doing clinical research? I mean, there is a traditional model, sites that are interested, we've worked with many of them, we have a clinical question that we want to answer, we go to them. Do you foresee almost like a public forum where ideas are generated out of those things? You identify sites out of those types of forums, and we take a sort of a community-based approach, although not in the actual physical community, but sort of in an online community where we identify investigators and questions.
So I think we're moving in that direction. I'm not sure how fast we're moving in that direction, and I think it's going to vary around the world and vary in different research spaces. In the more regulated, industry-funded, pre-approval space, it's going to be more challenging, I think, to try to leverage those kinds of networks. But I think certainly in other areas, it's going to come first, and hopefully it will allow us to do more efficient research, answer important questions.
Really.
Yeah.
No, it's social networking. It's Facebook for research.
Right. Yeah.
I think there's some really attractive things we can do in the future. And I like the idea of actually enrolling subjects through the internet, being able to follow them on the internet.
Yeah.
But, there is still the human social element of liking to work together and be part of a team. And somehow I think that as we evolve into more electronic media to support our research and dissemination of knowledge, we're going to have to figure out how to keep that spirit together, because there's nothing like going to the ACC meeting and walking down the hallway and seeing somebody, at least for me who does mega trials across the globe, seeing someone that I recognize from Delhi, India, and stopping and shaking their hand and saying, how are things going? Great to see you. And then having meetings where everybody comes together, and we have hundreds of investigators in a room talking about the data, talking about the trial, and that kind of connectivity will be harder to generate through social media. But if we can figure that out, then I think it'll even help, as John said, move things along.
Yeah, I don't think it's actually us who's going to do this. I think it's our kids. I mean, I have some young teenage kids who are very happy on social media. They don't see the need to call their friends. They just text, and they're just fine. And
right.
I don't live there yet.
Well, we're old.
Yeah, we're getting old.
my 6-year-old asks me, Dad, when can I have an email account? So
it's amazing, isn't it? Yeah, it is interesting. I mean, it's always a double-edged sword. There are certainly good things about it, but there are some dangers, I think, and that human element, I think, is a really important aspect of what we do in clinical research. Whether it's dealing with our colleagues or dealing with patients. I mean, fundamentally, this is clinical trial is a human endeavor, really.
Yeah.
So in the last few minutes here, tell us what to look forward to. What are things that we're going to be talking about at ESC, at AHA next year, some of the big programs that DCRI is involved in that we can look forward to in 2011?
Well, so I'll just start. There's been, we've seen a host of clinical trials with novel anticoagulants. There's a bunch more coming. And so I think the anticoagulant world is going to get, the oral anticoagulant world is going to get much more flushed out, I would say, over the next really couple years, both in atrial fibrillation, post-acute coronary syndrome. We'll have a lot of interesting data out at the upcoming meetings.
Ken?
Yeah, it's really exciting time. Unfortunately, we've recently had to stop a couple of trials here that people are well aware of. One that Dr. Alexander was helping run, and one that I was helping to run. And we're really eager to get those databases locked and analyzed, because, as people know, they were stopped because of some concern for bleeding. And what I think we're going to learn a lot about, Sunil, in the next 6 to 12 months as these trials come out is, are we pushing the envelope too far in terms of stacking anticoagulants on top of one another? We don't just have dual therapy, we often have triple therapy now. And what we can, I think, start to understand is, perhaps, is it a dosing issue? Is it a target issue? Is it the fact that we only need 2 or 3 targets, not 3 or 4?
Yeah.
And I think it's going to be a wonderful opportunity that will probably lay the foundation for how we engineer anticoagulant and antiplatelet therapy for patients with acute coronary syndromes and need for secondary prevention, probably for the next 4 to 5 years to come. So.
Yeah, in some ways, we've somewhat been victims of our own success. As we talked about the rival study, very low rates of endpoints overall. Do you foresee us including higher and higher risk patients in these trials? I mean, it looks like for the majority of elective PCI patients, for example, they do well regardless of the strategy that's used. You have to sort of pick the one that you're comfortable with and dose it appropriately.
I absolutely think we have to, because the population is continuing to age, and with age comes a number of comorbidities, unfortunately, that increase our risk. Our renal function goes down, for example. And if we don't include patients at higher risk, then we're going to be faced with what John said at the very beginning, who we need to know who we want to use the drugs and devices in, and we want to have the data to support the use in those kind of patient populations. And so I absolutely think we need to have as broad of inclusion criteria as we can in these trials, not restrictive.
Yeah, I mean, I don't think the risk of the population is going down. I just think we're selecting patients to put in trials. And we do have better therapies, but there's plenty of patients who have bad outcomes out there still. And some of that is on us to figure out how to design trials that we enroll our representative patient populations in.
And we could be successful. I mean, if you look at the Rocket AF trial, for example, that I had the privilege of being involved with, that we set out front. We want high-risk patients in this trial. And enrolled a patient population that had a mean CHAD score that was 1 point or a little even more higher than any other large AFib trial. I mean, so
it can be done.
It can be done.
But
it takes a lot of work.
Yeah, you got to have dedicated investigators, it sounds like. And then there's this whole other issue of implementation science, right? I mean, we've got all these therapies. Clearly, they're still underused, and that's probably a conversation for another day. But so it sounds to me like we still got a lot more work to do, and clinical research is alive and well. Is that a fair statement?
Yeah, we haven't solved all medical problems in cardiology yet. So
great. Well, I want to thank both of you for joining me. I hopefully we'll get to do it again after the next major conference and have more to talk about. Thanks again for summarizing the results of the ACC 2011 conference. Again, my guests today have been Ken Mahaffey and John Alexander, co-directors of the cardiovascular group here at DCRI. Until next time then, from all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.